Good evening. Thank you for joining this webinar on papilloedema and COVID vaccination. We will speak about cerebrosinus venous thrombosis, one of the severe complications. The talk will be a two-speaker talk. First, I will present as a neurologist on the background and neurological science, and then hand over to my friend and colleague in Copenhagen, Professor Hamann, who will present the ophthalmological view. Please do stay tuned in, because at the very end there are exciting news about artificial intelligence, and then the platform will be open for questions. Just to remind you, over 3 million of individuals already sadly died from COVID, and vaccine is incredibly important and effective. So whatever we discuss this evening, it is a small problem in the context of the larger problem, and the benefits of vaccination outweigh the risks. Having said that, you need to recognize the risks. And one is that after vaccination, you can develop blood clots, which can also affect the brain, and that is affected with a high mortality. The syndrome has a new name, VIPIT, which is short for vaccine-induced thrombotic immune thrombocytopenia. As a consequence, a number of countries paused vaccination with some of the COVID vaccines, and in fact Denmark stopped the AstraZeneca. So here's the index case in London, a 30-year-old lady who about 2 weeks after having had the AstraZeneca vaccination developed headaches, neurological symptoms, got brain imaging which shows on CT/CTV a sinus venous thrombosis. She later on developed thrombi also in the mesenterial vein and the portal vein, and the platelet count was throughout around 20. All other hematological tests had been normal, and it was just by sheer serendipity that Mary Scully, professor of hematology at UCLH, discovered that the FP4 antibodies were positive. This paper, just over the weekend, published in New England Journal, details a series of cases who developed this syndrome after the first vaccination, and the clinical details of these cases are by courtesy of Professor Marcel Levy. What is known about VIPIT? In fact, very little. The incidence is anything between 1 in 125,000 to 1 in 1 million people. We know it is roughly about 4 or 5 days to 3 weeks, 4 weeks after the vaccination, and mainly affects female patients under the age of 60. CVST is one of the more serious complications of CVIT, as you will see here. The WHO came up quickly with a flowchart how to diagnose it if patients have symptoms of VIPIT, and that includes headaches and blurred vision. Then we take a history if they had a vaccination in the preceding 20 days. If the answer is yes, you do a full blood count, and if the platelets are low, that's below 150, then again you continue with the hematological investigations, examine the dimer, look at the blood film, and if there are already clinical signs for CVST, to appropriate imaging. If the answer is yes here, you get in contact with your hematological colleagues about what further testing to be done, and that includes those tests we already know from HIT, heparin-induced thrombocytopenia. At this moment, I just pause to explain you the pathology of the syndrome here on the right. This is a wonderful review written by the group in Greifswald in Germany, who has a lot of experience with the syndrome, and I really like the approach by explaining HIT, starting with a bacterial infection. If you have an infection, on the surface of the bacteria you have positively charged polysaccharides, and the immune globulin recognizes them as a foreign antigen and mounts immune response as a defense. In fact, that's also what you do with vaccination. Now, biochemically, immune globulins are proteins made of amino acids, and they're negatively charged. So if you infuse heparin, and now we come to HIT on the left side, the surface of heparin has a lot of positively charged compounds, polyanions, so they naturally attract each other. The heparin positively charged, the IgG negatively charged attracts, and that can also trigger an immune response. Of course, you continue giving heparin, it coats the thrombocytes, and as the thrombocytes are coated with heparin, all the immune globulin attacks them, and the thrombocytes are effectively taken out, leading to HIT. Now, there are very few cases so far reported, and in the United Kingdom we have a system which is called the yellow card reporting. In fact, regarding only the AstraZeneca vaccine, there had been over 129,000 yellow cards filed for adverse reactions, and on the 5th of April, 100 of these were due to a major thromboembolic event with thrombocytopenia, and 50% of these cases were CVST, and then again of the total 100 cases, 22% died. These data are updated on a weekly basis, and I've given you the full link here where you can keep yourself updated, and the talk is recorded so you can look that up later. What can cause CVST? Here's another beautiful New England review by Jan Stam, a neurologist from Amsterdam, who compiled an exhaustive list of causes starting with genetic predisposition, infections can cause it, and I will come to osteitis and mastitis. There are a number of inflammatory diseases, hematological conditions, to which one would also add heparin-induced thrombocytopenia, we just discussed. Then there are a number of drugs, most frequently oral contraceptives, but there's some of the other drugs which should be added, mechanical causes, and a number of other reasons, dehydration, high altitude, vasospasms, and undoubtedly, when published again, this list will also include now VIPIT. So the thrombus affects the sinuses, and I've shown you in this slide two pictures. One is the anterior view, so if you have 3D goggles you can actually see that, gives a nice depth vision, and the posterior view of the sinuses. It is relatively easy if you start with the jugular vein, where the main blood comes out of the brain. If this vein is blocked, you have a serious venous outflow problem, stasis, increase of intracranial pressure, and quite substantial problems. Then the sigmoid sinus, the one behind the ear, drains into the jugular vein as the transverse sinus shown here. Then you have the straight sinus going deep into the brain, where you have the deep veins in the brain, a lot of anastomosis. That's where the veins of Trolla-Gallin and Labbé come in. And of course, the major sinus is the superior sagittal sinus, the longest one, and the one which you can't see in the posterior view is the cavernous sinus, which does affect the eye. To explain you the symptoms which happen, I will share my screen in a different way and show you a video. So up here you see again the slide you've just seen, and here is a video. And as you move into the brain, you see just where the transverse sinus is, and this is just below the temporal lobe. So any problem here will give, of course, headaches and seizures, which is what all of them have in common, and then contralateral pyramidal signs. If the vein of Labbé is infected, then you can have also aphasia and these type of problems. If you move further in, then you see here the deep venous plexus, which gives you frequently bilateral or alternating problems, coma, change of consciousness. And if you move further in, you see how the very long sagittal sinus comes out, and that can give you everything from seizures to visual problems, because here's the occipital cortex, which either can present as a hemianopia or as cortical blindness. And we just look a little bit further in, so I can tell you the story about the otitis. Here we have the sigmoid sinus coming down behind the ear, if an ear infection comes in here, then the symptoms include not only involvement of the 8th nerve, but also the abducens and the 7th and so forth. So these are the neurological symptoms to be aware of. And I move back to my presentation where I share an own patient which sadly died when I worked on neurocritical care. It's a 29-year-old woman who was pregnant at the time. And here you see the thrombus in the suprasacral sinus. And the reason why all of these patients of CVST die is actually brainstem herniation. So once the brain starts to swell, the brainstem will herniate here. And this is what happened over time. In this lady, it was my patient, she was unresponsive, so we had to give her a pressure measurement for intracranial pressure. And I show you 3 parameters here: the mean arterial blood pressure are the squares, then the dots are the cerebral perfusion pressure, which generally should be kept above 20 millimeter mercury, and then in the diamonds show you the intracranial pressure. So on anticoagulation, she remains stable for a week, but once it deteriorates, it goes very quickly. And that's to remember, this patient, if it goes badly, sadly, it goes very, very quick. So the algorithm of how to investigate is a practical, also highly recommended review in practical neurology by Ulvi et al. From Professor David Waring's group at UCLH. You suspect there is a CVT, then the European Stroke and European Neurological Guidelines advise MRI and MRV. We frequently do CT and CTV. And if it is confirmed, then you must start immediately anticoagulation. There's a risk score of these patients can deteriorate, but the bottom line is once the brain starts to swell, you develop cytotoxic edema in addition to vasogenic edema, and you need to really sit together with your neurological and your surgical colleagues to discuss if measurements such as decompressive craniotomy can be done, bearing in mind the cause for death is brainstem herniation. If you get the patient over the period where the pressure is high, a lot of the problems will recover. Having said that, you need to really get the pressure down because it can go wrong from the optic nerve, as you will see in the next case. This is the acute situation. 55-year-old lady, headaches, blurred vision. She had papilloedema with hemorrhages. Vision was reduced in both eyes to 6/12. There was dyschromatopsia, the Ishihara chart. She missed a couple of them. Eye pressure was normal, and she developed horizontal binocular diplopia. On examination, there was a bilateral abducens paresis, and that does actually lead into differential diagnosis of increased cranial pressure. The MRI does show a thrombosis which already went down away from the superior sagittal sinus all the way down into the right internal jugular vein, and the opening pressure was about 0.5 meter. These are the images. These are TopCon images. You see bilaterally swollen discs, and you will see much better images in a second from Professor Hamann. The discs are swollen, and the way I look at this, the veins look engorged. You have loss of venous pulsation, and the coloring of the disc is very, very helpful. If you look at capillaries, that's what I do. If I want to distinguish seeing a patient between early papilloedema, then the first thing I think which disappeared are the capillaries. You can't see them as the axons start to swell, and that distinguishes, I think, clinically well from pseudopapilloedema. In the left eye, it's difficult to see in this image the hemorrhage. So if you look at the red-free image, you see the hemorrhage here. And then, of course, there's the OCT with the swollen disc. And believe me, there are retinal wrinkles, but you will see more about that in a minute. The second case shows you what can go wrong if you don't get the pressure down quickly, because you kill the optic nerve. This 32-year-old lady recovered from CVST, but was blind to no perception of light in the right eye and 3/60 in the left. This is her OCT, and I just added here the macular thickness scan, where you see the ganglion cells are completely wiped out on the right and on the left. And then you also have the classical peripapillary retinal nerve fiber layer between the red and the blue line. Also severe atrophy. Just to give an impression, the green area would be normal, and the black in the right and the left eye is what you see in these patients. Of course, a lot of blood vessels artifacts here. So monitoring for CVST in a population-wide vaccination scheme we are in at the present is a challenge. There are service capacity issues. There's a high rate of urgent referrals already. Most of my urgent referrals now are exactly this type of problem. And of course, a common side effect of the vaccination are already headaches. The combination with a suspicious disc really puts you in the situation to be able to distinguish papilloedema from pseudopapilloedema, which the next talk will clarify in detail, and there is possibly a role for artificial intelligence. With this, I want to hand over to Steffen in Copenhagen, but not without really to thank Professors Marcel Levy, Peter Maloka, and Dan Miller for their contributions. And with this, over to you, Steffen.
All right, thank you very much, Axel, for this. And I will speak about papilloedema versus pseudopapilloedema in relation to VIPIT. And this is seen from the ophthalmologist's viewpoint. So start off with a case of a 49-year-old man, previously healthy, apart from anterior uveitis bilaterally a few weeks prior. In March last year, he starts to have some severe headache, photo and phonophobia, vomiting, and pulsatile tinnitus. And the patient thinks it's his uveitis reoccurring, and he takes inflammatory drops and painkillers. This doesn't help him, so he comes to the hospital where the blood pressure is very elevated. He is hospitalized and treated for this, and he's released the day after with no further action. So in June 2020, he still has his symptoms. They are fluctuating in severity, and at that time, a normal MRI of the brain is performed. So we jump to September 2020. He is seen in our neuroophthalmology department due to bilateral disc edema noted by his private ophthalmologist. And at that time, no further action is taken since he had a normal MRI and the papilloedema is very mild and the headache is not so severe anymore. So this is how it looks like when we look at his fundi. You can see a subtle disc edema on both sides. Not very extensive, but it's there. And if you do the enhanced depth imaging OCT of the optic discs, I'll get back to this in a short while we do this. You just see the elevated discs, and you also see these mass-like structures peripapillary. We'll get back to those also. So in March 31st, he's referred back to the eye department acutely due to increasing papilloedema, which is noted by the same private ophthalmologist that saw him the first time. The symptoms are still present, headache, tinnitus, and pulsatile tinnitus, and but they're fluctuating. So this is how he looks now, and now we have severe papilloedema on both sides. And you can see down here on the OCT that the discs are much more elevated, and you also see on the side of the disc the lumps are not really there anymore, but there are some peripapillary fluid leakage. So the day after, a CTC with venogram is performed, and it shows a thrombosis of the entire distal part of the right internal jugular vein, the right sigmoidal sinus, and the right transversal sinus. And a lumbar puncture is normal, but it has an opening pressure which is elevated to 34, and he started on antithrombotic treatment. And 1 week later, we see him back in neuroophthalmology, and now his symptoms are improving. He still has his massive bilateral papilloedema, but with a normal visual acuity and only a enlarged blind spot on his visual field examination. So to sum up this case, it's a very insidious onset of a cerebral sinus venous thrombosis. It took actually 1 year for the papilloedema to become severe, and it took 1 year to place a diagnosis. So the question here is, can we spot the diagnosis early on, and can AI help us with this? So we believe, as Axel also talked about, that the CVST causes blockage of cerebrospinal fluid absorption in the arachnoid villi. This leads to raised intracranial pressure and then to papiloedema. We anticipate, as Axel also mentioned, that the number of referrals with headache and or papiloedema post-vaccination will increase. So the problem is that the papiloedema may be subtle, as we showed with this case, and insidious. So the challenge for us is to differentiate between real papiloedema and pseudopapiloedema due to other causes. So when we look at the optic discs, there is a grading scheme for papiloedema called the modified Frisén grade, very well known. And here we have 5 grades. So it's very easy to say if the disc is normal, if it has sharp borders. So that's easy. And it's also actually quite easy to say if it's a grade 4 or grade 5 papiloedema with the severe blurring of the disc and the major vessels and hemorrhages as seen here. Sometimes it's difficult with the intermediate grades. You can look at the capillaries, as Axel also said, but it's still quite hard sometimes. And the reason why it's hard to say for sure that it's a subtle papiloedema is that you got the pseudopapiloedema. And the most common cause for pseudopapiloedema is buried optic disc drusen. So the drusen, they come in 2 flavors. You have the visible ones that are visible on the optic discs, and then the buried ones, which is actually the majority. And on the left, you have a 14-year-old boy with buried optic disc drusen, and it looks quite a lot like a subtle papiloedema. You also have other causes for pseudopapiloedema. It can just be that the optic disc is tilted, as seen in this 14-year-old girl, or you can have a very crowded optic disc. This is a 23-year-old man with a small crowded optic disc. It also gives you the impression of papiloedema. So the question is not whether the disc is normal or whether the disc is severely edematous. The question is this subtle papiloedema or is it pseudopapiloedema? So in this case here, you have to the left a patient with buried optic disc drusen, and to the right you have one with idiopathic intracranial hypertension. And in other words, you have to ask the question, is this potentially life-threatening? Because it could be that it's not just idiopathic intracranial hypertension. It could be a large brain tumor causing papiloedema, which is seen here in the case to the right with the 8-year-old boy with large brain tumor. And it's very hard actually to distinguish the two. And how about these 3? Now it becomes even more difficult just by looking at these discs. It's very hard to tell. So on the left we have a 14-year-old with buried optic disc drusen, and in the middle you have a 29-year-old with a large brain tumor. You see the size of this tumor and only very, very subtle papiloedema. And to the right we have a 27-year-old with cerebrovenous sinus thrombosis. So just by looking at the discs, it's actually quite difficult to distinguish the two. So the question is there a simple, non-invasive way to diagnose pseudopapiloedema due to buried optic disc drusen? And the answer is yes. So we can use enhanced depth imaging, optical coherence tomography, or EDI-OCT. As I mentioned, the majority of the drusen, about 60%, lie beneath the surface of the optic disc, just a bit like an iceberg. So we've come a long way since the first OCT scan of optic disc drusen was shown back in 1998 by Rowe and colleagues, via the non-enhanced depth imaging SD-OCT, and now to the enhanced depth imaging OCT, where we can see the posterior border of the drusen. So in the International Optic Disc Drusen Studies Consortium, we have come up with a scanning protocol that we suggest that you use in order to capture these drusen. I'll not go through this in detail, it's available on our website. But the most important thing to mention here is that we do a dense optic nerve head scan with 97 sections in that area. And the reason why we scan with so many scans is that with 97 sections, there is 30 microns between each scan. And by doing so many scans, we're sure to capture all the drusen. So these are our guidelines for diagnosing drusen. They always have a hyporeflective signal per core, as seen here. They are often seen with a hyperreflective margin. This is most prominent superiorly. The prelaminar hyperreflective lines, as you see down here, they may represent early drusen, and the peripapillary hyperreflective ovoid mass-like structures, abbreviated FARMs, these should not be diagnosed as optic disc drusen, and they probably just represent herniated retinal nerve fibers and crowded discs. So the vessels sometimes mimic drusen, but they're tubular and they cause shadowing of underlying structures. You see here the shadow goes all the way through here. Okay, so we can do a manual volume segmentation of the drusen, as seen here. It is a very laborsome work. It takes a lot of time, but of course it gives you these nice images. But another approach which is emerging is the automatic volume segmentation using the AI. And this is from Professor Michael Girard in Singapore. And to the left, you have a patient with papiloedema, and what the computer has been fed with hundreds, if not thousands, of OCTs, enhanced depth imaging OCTs of papiloedema discs, and now he's able with this deep learning system to show all the different layers of the retina and of the optic nerve, and this is quite nice. And you see here to the right. You see the optic disc drusen. It shows up as a blue structure lying here beneath the surface. So this is very nice. We'll get back to this. So what about the FARMs? I'll just mention quickly. These are seen often in drusen, as seen up here to the right, but they are seen in disc edema of all other causes. So it's an unspecific OCT marker of exoplasmic flow stasis seen in crowded discs. Up here you have a disc from a patient with papiloedema. Before and after treatment, you see the FARMs, it diminishes in size. Here you have a patient with ischemic optic neuropathy, a patient with central retinal vein occlusion. Here, down here in panel F, you have a patient with optic neuritis before and after the neuritis goes away. And here you can also see it just in tilted optic discs or anomalous discs of various causes. When we started to describe these FARMs, we thought that one disc had multiple FARMs, but now we know that it's actually one FARMs that goes all the way or a part of the way around the disc, kind of like a donut. And here in this little video animation, you can actually follow the FARMs here. You can just follow it all the way around. You can see here is a peripapillary region causing the pseudopapiloedema. What about the hyperreflective lines? We did a study where we followed young individuals at the age of 12 and again at the age of 17. So these are not patients, just regular adolescents. And we see that all the patients with drusen, they had also hyperreflective lines. And in the 12-year-olds where we saw hyperreflective lines without drusen, these became drusen when they were 17-year-old. So this progression from hyperreflective lines to ODD support the concept that these lines are potential ODD precursors. But actually, we also see them following papiloedema. So we recently did a study where we looked at IIH patients with idiopathic intracranial hypertension 3 months after their edema has subsided. And we saw hyperreflective lines in 31% of these patients using EDI-OCT, as shown in this example here. So what we conclude is that the hyperreflective lines, it's probably a crowding phenomenon seen as FARMs, seen in congenital crowded discs, where they have the potential of developing into ODD. And they are also seen in acquired crowded discs, such as in papiloedema, where they persist post-papiloedema, but they do not develop into ODD as the papiloedema resides. You should be aware, of course, of coexisting papiloedema and buried optic disc drusen, because, of course, the drusen do not give you protection against papiloedema. And this is a nice case from Professor Patrick Sippeney in New York, showing an 18-year-old female with papilloedema, as you see here to the left, and obstructive hydrocephalus and drusen. So here you see the dilated ventricular system on the scan here, and this is the en face OCT, where you see the peripapillary wrinkles and folds that Axel also mentioned. And if you do the EDI OCT in the acute stage, you can see the elevated disc here, and here you have the impression that there's a drusen down here. It can be quite difficult to see in the initial stage, but after this patient was treated with a shunt, you see a drusen lying nicely down here below. So be aware of this combination. So how do we approach this in the clinical setting? Of course, if you have a patient with severe headache and really loss of consciousness, feeling bad, you go straight ahead to the scan. But if the patient is relatively calm, you can do the EDI OCT to look for drusen. And then the next question is, of course, to ask for symptoms of increased intracranial pressure with headache, vomiting, pulsatile tinnitus, and all that. And if there are symptoms of increased intracranial pressure, we do acute CTC and a CT venogram. That is how, at least, we do it in Copenhagen. And so here you can end up with a mass lesion, thrombosis, or a normal scan, perhaps with signs of raised intracranial pressure. And in that case, you proceed with workup for IIH. If there are no symptoms of raised intracranial pressure and no drusen on the scan, well, you should consider other causes of optic disc edema. And if there are symptoms of increased intracranial, if there are no symptoms of increased intracranial pressure but drusen, then the diagnosis is drusen. So back to our case that I showed you to start with, the 49-year-old man with CVST and insidious onset. The question is here, can AI help us? And I showed you the images in the early stage where there was only subtle papilloedema, and then 1 year down the line in the late stage with a severe papilloedema. And so I asked our colleague, Professor Dan Milea in Singapore, to test the bonsai algorithm to see if it could predict whether there was papilloedema or not. And in the early stage, it said that there was 74% probability of papilloedema in the right eye and 85% in the left eye. So this is really good, actually. And in the late stage, where it was also quite obvious for us humans, it said with a very, very high certainty that this was papilloedema. I also asked Professor Girard in Singapore if he could test his algorithm using the enhanced depth imaging OCT to look through the disc. So this is from the early stage papilloedema. Here again, you see nicely the different retinal layers. And we look also here for the blue structures, which are the drusen, and there are no drusen at all. So you can just flip it around, seeing from the different sides. So there's 0% probability of drusen in this case and 100% probability of disc edema. So to sum up, if you have no papilloedema or severe papilloedema, it's quite easy to diagnose on fundoscopy. EDI OCT is well suited to distinguish between subtle papilloedema and pseudopapilloedema due to buried optic disc drusen. The farms and the prelaminar hyperreflective lines are crowding phenomena seen in both conditions and therefore not useful as indicators of one or the other. And the best way to distinguish the two using EDI OCT is to simply diagnose the ODD, looking for the characteristic hyperreflective structures. You should always be aware of coexisting drusen and papilloedema. So the peripapillary wrinkles, folds and creases, as well as peripapillary fluid accumulation in patients with drusen are signs of coexisting raised intracranial pressure. And the use of AI will be of great aid to us in the near future. So finally, I'd just like to thank the ARS Consortium, which is spread around all over the world, as you see here in this map, and to Professor Michael Girard for his very nice video animations. So with this, I'll end my talk, and I'll be happy together with Axel to take any questions.